Greetings, everyone. So this is our first podcast with Dr. Moran. So he was gracious enough to allot some time with me to ask him some questions that pertain to the new medical directives in 5.4, and overall just see his perspective on different treatments, the different medications and therapies we can now give, and overall just get an insight to how these directives were created. So the following will discuss what he thinks about ketamine as an analgesic medication. If PCPs can use the gastric port that was placed by the ACPs when it's in the stomach, whether TXA can be beneficial for those experiencing esophageal varices and or like postpartum hemorrhage if paramedics patch them. All that will be found in this podcast. We hope you enjoy. If you have any questions or any topics you want to see, Dr. Moran is so kind enough to offer more time to doing these so you can get his insight and he can communicate his professional expertise in these topics. So we hope you enjoy this format. Well, thanks for doing this.
Sure.
Yeah, so the purpose of this is just kind of discuss the new medical directives and maybe the history behind them, just the nuances, because I ask you probably a million questions every time you come in. And we always have good conversations. Everyone appreciates it, and I know paramedics will appreciate this too. But
yeah, no, happy to try to help out.
Yeah. Okay. Can you kind of give like some of the background of how these directives came to be?
Long story short. Well, these particular directives, they never come in as sort of a group package, right? So what'll happen is over time, different directives are proposed and go through our approval process. So for example, the defibrillation, dual sequential, and vector change are all based on the findings that Dr. Cheskas's study found. And so in order to maintain ourselves at kind of the highest level of evidence-based care, we're moving forward with those changes. And that's typically sort of the approach to this. Some of them are taking advantage of some of the medications that we currently have. So, for example, ketamine. Ketamine we are currently using for the combative patient, and now because it's recognized as an analgesic agent, and now that people have the comfort and training to be able to use that medication, we're opening up that option as well. The traumatic hemorrhage has actually been something that's been in the works for a number of years. So we've been exploring the evidence back and forth for TXA. And in fact, initially, there wasn't enough evidence to support it moving forward. But then as time has progressed and there's more and more evidence that's become available, we've recognized that is now would be considered the standard of care to administer that early. And so that's why we're now rolling that out as part of the that particular area of care. What else we got?
Perfect, because basically, like you're part of the medical advisory committee, and everyone just goes over the recent evidence and discusses how is this relevant to paramedic practice. Then,
yeah. So we typically, like, the normal process for a directive coming forward is that it doesn't have to be like initiated by a medical director. So if, like, for example, if a paramedic has an idea about a directive that they think would be an interesting or be appropriate for pre-hospital care, they can bring that forward to their base hospital for consideration. And ultimately, if we feel that the medicine behind it is sound and that the evidence behind it is sound, then that can be brought forward by the medical director at that base hospital to the other medical directors for discussion to see whether or not everybody's on board and or if any further evidence is required. And then again, ultimately, if there's enough agreement at the table, then that will go forward to the MAC for approval. So I think the point is that anybody can propose a medical directive. So if you ever have any thoughts about something that you think would be useful or indicated, or even have you're curious as to whether or not that might be something that might be useful in the pre-hospital setting, then I would encourage paramedics to bring those ideas forward.
I don't think most paramedics know that.
Yeah, no, anybody can propose something, and we're happy to look at it. We as sort of the base hospital physicians we try to stay on top of the evidence and promote best practice. But again, can't have a lens on all of it, and often the paramedics do have a different perspective because there are things that you're seeing and may wonder maybe there's a better way of doing this.
Okay. So speaking of TXA and trauma,
yeah,
why is it beneficial?
So early administration of TXA and trauma has been shown to improve survival in non-isolated head injury patients. So the current standard of care is that TXA is administered again as early as possible in the management of the trauma. So historically, that's always been done in the emergency department. There is now some evidence for use in the pre-hospital environment for the use of TXA, and that's probably why things were sort of held up previously, as there was no pre-hospital evidence. Now there is some pre-hospital evidence showing that it does improve survival, and so that's why we've now moved this to that environment.
So if somebody got like stabbed, shot, or pelvic fracture, you'd recommend TXA?
Absolutely.
And the key is as early as possible.
Right.
So how come you can't give it after 3 hours then?
Well, again, the evidence is supportive of early administration of TXA. So after there's been, again, with the time frame that's gone by and there's ongoing active bleeding, the benefits decline over time, just as the survivability declines over time with active hemorrhage. So that's just where the evidence has pointed us, is into that early administration.
Perfect. How come not isolated head traumas then?
Well, that's again because there is actually, it's been a couple of studies that have looked at it specifically for head trauma, and it has shown no benefit. One actually had a sort of a trend towards decreased survival, but not statistically significant. But because there's no evidence supporting its use, therefore we're not advising it just for those.
But if someone had poly trauma,
yes,
like they had a head injury, suspected pelvic fracture, you could go ahead with it?
Yes.
Because the benefits outweigh the risks at that point.
Right.
Good. And our current directives say we should infuse it over 10 minutes. How come?
To be honest, I think that's really more out of the manufacturer recommendations for it. I'm not aware of sort of specific evidence that would show that if you gave it too quickly, that it would cause harm. But I believe it does have some minor vasogenic effects. So if you push it too quickly, it can actually cause a little bit of hypotension associated with it, as far as I'm aware.
Mm-hmm.
Yeah.
So the preferred route is IV route or IO for ACPs?
Yes.
Yeah. But obviously if you can't get an IV, IM injection as soon as possible is preferred.
Yes.
And we can only do 5 mils max for each vastus lateralis.
Yeah.
Is there concern if they have a broken pelvis if we give the IM injection in the thighs?
No, because you're still perfusing those muscles well. So it's different than putting central lines, of course, when we're putting those in, where you could have actual vascular disruption. But even if there is a pelvic fracture, you're still perfusing the thighs, and so you're still going to absorb the medication.
Perfect. But if you're going to do it through an IO, should be
Should be upper extremity. Yeah.
So the age requirements for TXA is 16 at this point in time. Mm-hmm. Let's say a 10-year-old sustained trauma and they're bleeding.
It's again, although it may seem like intuitively you would say that probably is going to be effective in the 10-year-old. The evidence is not supportive of that at the time. So we're really trying to stick with, what evidence-based practice is.
Perfect. So you don't want cruise patching practice, the evidence is non-existent at this point in time. But we talked about this last week of, like, let's say you had the resources and the time to do it. If someone had esophageal varices and they were unstable, could you patch for TXA?
Yeah, so that's one of the advantages of being able to call in, is that if we have a medication where you have the understanding of the medication, the training and the contraindications and that sort of thing, you can certainly call in for a physician consultation if you think that it might be appropriate. So TXA is useful in other kinds of bleeding. And so in emergency departments, we will use it for nosebleeds. Its original indication is for menorrhagia. So if people have heavy vag bleeding, Or again, really with esophageal varices, like it's really any sort of active bleeding can be a consideration for TXA. So you could call in and have a discussion about that.
That's a good segue. So if somebody's experiencing post-param hemorrhage, and again, we've done the other therapies like oxytocin, bimanual compression and time, do you think they could patch for TXA for that?
Yeah, I think that would be appropriate.
Yeah,
too.
perfect. Yeah. Excellent. So double sequential. So you kind of talked about this at the beginning. Why is it actually beneficial?
So, keeping in mind that it's for refractory VF, it's not your initial treatment for somebody with VF, but in the study that Dr. Chesky's published, and recognizing that the numbers are relatively small, but it did show that there was benefit in primarily in double sequential. So that shows the better benefit, but there's also benefit in vector change, not quite as strong as for double sequential, of getting a return of spontaneous circulation and ultimately survival from that. The thought, yeah, and again, this is all hypothesis, of course, but the idea with the double sequential is that initial shock sort of primes the heart, so it sort of lowers that electrical resistance through the chest wall, so that the second shock has a better delivery to the myocardium than the first one did. The thought behind vector change is a little bit different in that a shock is delivered, it is ineffective, but it might be more effective if it's delivered from a different angle at the heart. So there may be less resistance in the one direction versus the other. So, utilizing those changes in pad position may allow for better electrical delivery to the heart and better effectiveness that way.
But if you had a choice, you'd prefer double sequential over vector change.
So that's in recognizing what resources are available, etc. The double sequential has been shown to be a little bit more superior. And again, I can't emphasize enough that these are small numbers. Like we're not dealing with the study did not have thousands of patients in it. But there are definitely some restrictions as far as machine availability and being able to get a second defibrillator at the scene in the appropriate amount of time. But if you do have two machines that are available, that is probably the preferred method, yes.
So Dr. Cheskas, correct me if I'm wrong, excluded people that had like drug overdoses, drownings, and hangings because they weren't cardiac origin.
Right.
What would you think if somebody was in a cocaine overdose and it led to an arrhythmia and then refractory VFib? Excluded or patch considered?
I think it would be useful for a patch in that situation. Yeah, because I would certainly, if they were refractory VF and that had been sort of the inciting episode, I would still consider it, because normally, again, in the cocaine overdose that leads to cardiac arrest, that's probably from some sort of occlusive event of the myocardium. And so ultimately the sort of underlying pathophysiology is going to be quite similar to if they had an MI from a clot formation. So
that makes total sense.
I think it would make sense to patch.
But with the hanging and the drowning, unlikely to be in shockable rhythms, but
right. Yeah.
Good. So what do you think, broadly speaking? Ketamine is an analgesic.
So ketamine is useful as an analgesic. It would be considered several lines of analgesic lower than what is currently available. So with availability of morphine, of fentanyl, which are really have been well proven to be effective, titratable analgesics. And then we also have ketorolac, which again, a reliable analgesic that we've been using for quite some time. Ketamine is a good analgesic. It's useful, I think, primarily where I've seen it useful is in cases of people, for example, with back pain where they have sort of failed your traditional therapy. When I have used it, it's primarily as kind of a fallback from the other ones. So I've given morphine, I've given lots of morphine. I haven't had any sort of result that I'm happy with, and then I'll look at potentially switching over to ketamine. But it's really rare. I've used it very little actually in my career. So I think it's something to recognize as being available and as an option, but I would never use it as my first line option.
Because that's the key, like the provinces anyway with the direction of it's not a first line analgesic for those reasons. Yeah. I know we talked about this multiple times that let's say you give 100 micrograms of fentanyl and they're still not responding well. Mm-hmm. Do you think you should switch to ketamine that way, or should you just try more of a dose?
I would actually try a higher dose. Yeah. 0.1 per kilo of morphine will give relief to about 50% of people who get it. So, if you think in the case of morphine, where we're, your average 70 kilo person, 7 milligrams of morphine is only going to relieve about 50%, and then the other 50% are going to require more. So I think you want to make sure that you give an appropriate dose of the analgesic that you're currently using before starting to think about switching around to other stuff. Safer to have one drug in your system than starting to mix up and get several in there.
That's good to know, because I know if we come to our max on our current medical directives of 200 mics of fentanyl, people think like if I go beyond that, maybe that could lead to adverse events. But it's all in context. If I broke my femur and I was still in severe pain with 200 mics on board, you'd be comfortable with the paramedics patch and said,
absolutely. Yeah. And if the person, the concern always that people have is they're going to make them stop breathing. But if a person has received 200 mics of fentanyl and they're still yelling at you and telling you how much pain they're in, they're clearly not close to stopping breathing. So I think you're safe to patch in and get another order for more pain meds.
Good. So you kind of covered the multimodal approach to analgesia. You said it's safer to usually have one medication in your system, but sometimes it could require another medication.
Yeah, I think, for example, the renal colic patient where there's sort of a synergistic effect between receiving an NSAID plus an opioid analgesic. So having access to those to different modalities can actually be beneficial, and also sometimes means you can use a little bit less of an agent. Again, it's always a balance between making sure that you're using maintaining safety. So again, I would not recommend having morphine and fentanyl and ketorolac and ketamine all on board at the same time. It's just the risk of all of those things interacting, but also recognizing that sometimes a single agent is not going to get you where you need to be. And so, for example, I think we're frequently using Tylenol and Advil together, and that's a very acceptable practice. I think using an NSAID with an opioid is also very acceptable practice to do as well.
Is there currently a patch point in the new directives? Like, let's say I started with morphine, and for some reason I decided I need to switch to fentanyl. Would you have to patch at that point, or could you just do it?
I'm always very reluctant to do that. So I think that there's a thought that switching opioid analgesic for another opioid analgesic may be more effective. I'm occasionally asked that in Emerge, where I'm giving morphine to somebody, like, can we switch to fentanyl or hydromorphone or something like that? And I think it's more the more appropriate way to approach that is to continue administering the same medication rather than starting to flip back and forth between different opioids.
Totally makes sense. Yeah. So let's say someone has opiate use disorder. Yeah. Would you go right to ketamine in that part, or would you try maybe an opiate, or maybe an opiate with ketamine?
I probably would still try to manage their pain the way we normally would. So if they are having acute pain, that unless the person is specifically saying, I don't want the narcotic, which they may, because they're trying to manage manage that type of symptom, we still have an obligation to treat pain as best we can. That being said, if there was significant concern on the part of the paramedic that may have an adverse effect by giving those medications, then you could consider using ketamine, as they probably would not require the same high doses of the medication as would be required in somebody who has a significant tolerance to opioids. But I think initially my initial approach would still be to try to manage their pain using standard therapy.
Because I know obviously with everything's going on with the opiate epidemic, people are concerned we may cause addictions.
Yeah, I mean, the acute management of pain is not what's causing the addiction. It's the people being sent home with prescriptions for things, and they're on it for a longer period of time. But treating somebody once in a pre-hospital environment is not going to create an addiction. Yeah.
100%.
So if someone has like trauma, let's say they got stabbed, they're hypotensive, and they're in 10 out of 10 pain,
Yeah.
what do you think of fentanyl for an analgesic then for them?
I think like anybody where their vital signs are stable enough to receive an analgesic should receive some sort of analgesic. And I think fentanyl is a great one. It's because it is so short acting that even if it were to have some sort of hypotensive effect, which is really rare that it would, but even if it did, it's going to be out of their system fairly quickly. And so you're not having to sort of try to chase your tail on that one to correct it.
Is that why they removed the blood pressure parameter for 5.4? Because for fentanyl, they got rid of normal tension.
Yeah.
They're good. So it's not truly as vasoactive as.
Right.
That's really good to know.
Mm-hmm.
So that kind of brings us to like procedural sedation, because I know I've been asked this question a bunch. Yeah. Would you recommend paramedics patching for ketamine if patients are going to see cardioversion or pacing?
Yeah, I think it is something that could be considered as a conscious sedation. It's a little bit trickier, I will say, that because the use of medications for conscious sedation, the whole notion of conscious sedation is really an emergency department procedural thing. So, for example, if I'm administering conscious sedation in the emergency department, that's my job. I'm not doing the procedure. I'm monitoring the patient. I'm monitoring their airway along with the respiratory therapist, and I'm only managing that. Whereas, like, I'm not trying to sedate them and do the procedure at the same time and monitor their airway. It's just the risk is too high. So the same would apply, I think, in a pre-hospital environment, that if you're sedating somebody with something like ketamine, which is actually a dissociative anesthetic, that there is risk associated with that if you're trying to do multiple things at the same time. The alternative is to try to manage their pain and manage their symptoms using fentanyl, potentially using midazolam, where you have less likelihood of having some of those complications associated with it. So it really depends on the situation. So I think it's something that you could use, but again, you have to just be aware that it's not the be all and end all. That now that there's something that can be used as an anesthetic in the pre-hospital environment, it's safe to do so, and they should just consider using that every time you do a procedure.
That's good to know, because people are worried about the synergistic effects of midazolam and fentanyl together, but truly, would it cause enough hypotension when you're trying to correct the cause of the hypotension if you're going to pace or cardiovert?
No, the always going to be airway stuff. I would not have a lot of concerns about it. Like, for example, if you're going to pace somebody, their hypotension is being caused by whatever underlying cardiac rhythm or lack thereof that they have. And so giving a medication that's a little bit vasoactive, that's not making the condition worse. Like, ultimately, you want the definitive management of the condition is by pacing. So I wouldn't have any concerns of doing that. It would just, again, you have to be conscious of the fact that you don't want to give so much that they have a decreased respiration as a result of that. And that would apply across the board. So bit of an advantage with ketamine in that it tends to have much less in the way of effect as far as breathing goes. But again, there's other possible complications whenever you're using a general anesthetic.
And correct me if I'm wrong, especially at that dose, if you call for procedural sedation, like that dose is high, that could lead to the increased risk.
It is definitely higher. It's considerably more than what you'd be using for analgesia dosing. And so it's not something that the paramedics would typically be doing and using it that dose is that high.
Especially we can do aliquots for the midazolam and the fentanyl.
Right.
That reduces the risk. Yeah. So that's really good to know.
Yeah.
And the last couple of questions, because now we can suction the gastric port.
Yeah.
How come that came out recently when we've had iGels for a couple of years?
That's a good question. So it was actually a proposed medical directive a number of years ago. Mm-hmm. And at the time when the iGels were being considered and the supraglottic airways for PCPs, it was not felt that there was any need to introduce gastric suctioning through it at that time. The focus was more on the procedure itself in enabling paramedics at all levels to use the supraglottic airways, and it was felt to be low risk. It was recognized later that these did actually have gastric ports where, sometimes people would end up getting a little bit of a face full of stuff while they were managing them. And then ultimately, the question came back around after they'd been in use for a while as to whether or not we could consider using the gastric port. Now, introducing a suction catheter into one of those invariably will lead to something being introduced past the glottis, which then makes it into a delegated medical act, and so requires a directive to go along with that. And so it now allows for that to occur if you're getting a lot of stuff either coming out the tube, or if you think that they're at high risk, if you have gastric insufflation, etc., that you can actually suction through it.
That kind of bridges my next question, because obviously, like you said, beyond the glottis, only ACPs can do that.
Right.
What if the ACP places the suction tube? ACPs technically suction if it's in place, if let's say they're busy logistically.
So technically no.
Yeah.
There's been some discussion about whether or not a PCP could suction through that port if they don't introduce the suction catheter down all the way through the supraglottic airway, because then technically it doesn't progress past the glottis. And so anatomically it's a little bit splitting hairs, but in theory it would be sort of similar to suctioning out a mouth. But just as with any other procedure, the actual suctioning past the glottis, it's still considered as something that's been introduced past the glottis and would be an ACP procedure.
Yeah, makes total sense.
That's all the questions. Anything you want to say or clarify or wish everyone?
No, I just, I realize that there's a lot of content in this CME, and I'm at the same time, I think it's all really important stuff, and I think it really helps to advance the practice of paramedicine. I'm really, and I have said this many times, I know, but I'm honored to be a part of this. And anytime anybody has any questions, I think we're creating a new forum for people to be able to ask those questions, where either myself or one of the other medical directors can reply to those. And so I would encourage people, if you do have questions, don't hesitate to bring those forward. There's always things that we don't necessarily think about, and there's always things that you're going to run into on the road that, I, as a physician who works in an emergency department where everybody's all nice and cleaned up and brought in packaged, I don't consider those things. So I would always encourage you, if you think that there's something that would be a good question or something that would be a useful thing to bring forward, please do so.
No, it's really appreciated. All your support.
Yeah, thank you.